Well, I'd like to welcome you all to the Internal Medicine Grand Rounds for this month. I have the pleasure today of introducing Dr. Alejandro Moreno, who is a physician, an attorney, and educator who's had a life of service throughout multiple facets, packing multiple careers into one through various facets, where he currently serves at the University of Austin, or University of Texas, Austin, as assistant dean to the development of clinical professional skills for skills integration for his students. He's mentored several residents and students over the years, but also has a medical practice in Austin currently. Over the years, he's done quite a bit of consulting work and advocacy work, serving as a consultant to different United Nations panels, as well as attorneys general of Honduras and Mexico over the years. As well as doing refugee and human rights work in the United States. He served at the University of Boston and currently serves at the University of Texas, and it's our pleasure to introduce him today. He is currently the governor of the ACP chapter of the University of Texas, and we've been looking forward to hosting him for some time through Dr. Larson's connections with him through the American College of Physicians. So without further ado, I want to let Dr. Alejandro Moreno take the stage here. So thank you.
Good afternoon, everyone. What a pleasure being invited to give grand rounds to you today, and especially to my dear friend and colleague and co-governor, Dr. Larson. I know he was not able to be here today, but he's present in spirit and heart. So we're going to talk today about Advocacy Beyond Leadership Day. And I don't have any disclosures. I think the most important things is I changed the names of some of my patients or clients that I'll be presenting some clinical vignettes. So the objectives of this talk is to really review the various spectrum of activities that fall within advocacy. This is really grounded on ethical principles and a legal obligation as physicians. I'm going to describe the pillars to become a really effective advocate for our patients. And then we're going to talk about how you can be, again, an effective advocate for patients, whether it's on your own or partnering with an attorney. Now, I think when we talk about advocacy, we all tend to gravitate towards, Leadership Day, whether it's in Washington, D.C., or in the local legislature. So on the left, you see us, this is part of the Texas delegation this past summer in D.C. This was part of ACP Leadership Day. And on the right side, you see a group of residents at the rotunda of the Capitol here, just a couple of blocks from where I'm sitting. And the residents here from UT Dell Medical School, from Baylor Scott and White, from UT Southwestern, coming down and visiting the representatives and senators. So I have to make the joke. I'm sure you already recognize the tall and handsome guy. Yep, that person right behind me is Dr. Roger Ketten. He is the chair of the Board of Governors of the American College of Physicians, one of our college leaders, dear friend, and a really good advocate for medicine and patients. Now, I don't know how many of you know that you can go beyond just visiting your representative or senators. You can actually testify in front of Congress. And this is an example.
Next up, Alejandro Moreno.
Good afternoon, Mr. Chairman and distinguished committee members.
My name is Alejandro Moreno. I'm an internal medicine physician, and I'm also an associate professor of internal medicine at the newly minted UT Dell Medical School. I work training medical students and residents just 3 blocks away from here. I'm here as the president of the Texas chapter of the American College of Physicians. The college is the second largest medical organization in the country with more than 140,000 members. In Texas, the college alone has over 7,000 members. I want to ask you to restore the funding for the statewide preceptorship program, a program that was run by the Texas Higher Education Coordinating Board in partnership with the Texas chapter of the American College, the Texas Pediatric.
So you can get invited by Congress to testify on a matter. When Congress invites you, most of the times is a committee that is considering a specific bill. You get plenty of time, as much as you need to testify. You probably have seen, oh geez, I'm blanking from the. Oh, he's one of our nation comedians who is a really outspoken person for the 9/11 first responders. John, my God, I'm blanking his name. In any case, he got invited. He testified into the health aspects of all the first responders, got all the time. You can also have non-invited testimonies. Usually you only get 3 to 5 minutes. So how you conquer the topic is by dividing. For instance, in this case, I was the 4th person talking about the statewide preceptorship program. It is a program that has been sponsored by the Texas Family Medicine, the Texas Association of Pediatrics, Texas ACP, and the Texas Medical Association. And it was a public partnership. We got public funding, and it was a really important program for professional identity formation of students during their preclinical stages. Back in the 2010s, the funding got cut because of budget constraints, and it took us 8 years to get it back on track. So it was an effort across the specialties, across multiple representatives and senators support the matter. So it took a lot of work behind the scenes, and the culmination was testifying in the committee that does appropriations for the state of Texas. So this is another aspect of how you as a physician can participate. So,
Next up.
But where we're really going to focus today is not about visiting Congress or testifying before Congress. It's really what Dr. Frank Maskins, who is a distinguished professor at the University of California, Irvine, coined. The physician is the natural attorney of the poor. And this is not an add-on. This is really at the core of our profession, is justified in ethical principles, in beneficence and social justice. The American College of Physicians, the American Board of Internal Medicine, ACGME have named as a professional obligation that we advocate on behalf of our patients. And there is also a legal obligation. It's a part of our fiduciary duty. A fiduciary duty is the obligation of always having the patient come first. We are in a position of privilege by knowledge and training, and that position of privilege is of service to our patients. So now, to really be an effective advocate, there are 4 main pillars: education, good documentation, knowing the social history of our patients, and being curious. And you're probably thinking, what is curiosity? In layperson's terms, is having a big mouth, meaning you will ask questions. And as internal medicine physicians, I know you're not shy about asking questions and trying to put things together. I'll go more in detail later as to that. So now, patient education. I think, or without doubt, the person who really put education at the forefront of advocacy was Dr. Jonathan Mann. Jonathan Mann was an internal medicine specialist, infectious disease and public health expert. He was the first director of the UN AIDS program. He died tragically in the Swiss air disaster out of Nova Scotia. But this is in the late 80s, early 1990s. He said, for us to control the HIV epidemic or pandemic, we are not going to be successful at using the traditional public health interventions of quarantining, isolation. It's through education. Education will empower the patients with HIV, and by empowering them, they will be in a better position to advocate for themselves. And, especially in some areas, education was a big factor. Abuse was another factor. Lack of access to healthcare was a major factor in the spread of the pandemic. And that really proved true. So now, every encounter with a patient is a unique opportunity with educator. And I'm guilty of this. I think we have been very paternalistic when we talk to our patients and we just say, you need to take this medication or you need to this, without really giving a context, a foundation as to why. And that has given a good opportunity for misinformation and disinformation to percolate. And now we're playing defense and trying to catch with the current situation that we're living today, particularly with vaccinations, reproductive health care. So just to mention a few of them. So I think we need to do a better job about really educating. Now, I think that the toughest part is really identifying the lowest hanging fruit. What do I mean by that? You can divide your patients in 3 tiers. There will be a small segment of your patients that no matter what you do, you won't be able to convince them or educate them as to certain things. Even if you have trust and a longitudinal relationship, they're not going to change their mind. There's another segment of the population that you can tell them, jump from the 10th floor of this building, and they will trust you because they just trust blindly on you, no matter what. And that they're already on your side. You don't need that effort that much. It's really the segment where you need to build rapport, trust, and a continuous longitudinal relationship to do it. Let me give you an example of how to do it. First of all, remember, there are so many topics that you can teach and educate patients that is impossible to tackle all of them. So choose one thing. What is the most impactful thing that you can teach them, depending on your patient population, depending on your setting? Is it rural? Is it inner city? Is it aging population? So you have to make that own determination. Always stick to the facts. Don't be condescending. Don't say, I know more. I am the one who did college. I went to medical school. You lost the battle if you do that. That is very paternalistic. As the old Chinese proverb goes, remember, you have 2 ears, so you have to listen twice as much as you talk. And that is very important because often the patients might have from personal experiences, religious, cultural experiences, some concerns about some therapy or intervention. And unless you consider them, might not be willing to adopt what you're trying to recommend for them. So, and that is the foundation to really correct misconceptions or misperceptions. The other most important thing is, remember, even though you have the medical degree and years of training, you might not be the most credible person in the room. So let me give you an example. I consider myself a traditional internal medicine specialist, although because of my responsibilities here at the medical school, I was forced to reluctantly give up my outpatient practice. So not right now, I'm doing just primarily inpatient, but in a very recent past, I was doing clinic. It's a federal qualified health center. The vast majority of the population is vulnerable: African Americans, Latino, and of those immigrants. It is almost universal. There is a misconception in the Latino population that insulin is the element that causes blindness, causes amputations, and renal failure. And the misconception goes because in the old days, we used to prescribe sulfonylureas and metformin for patients for years. And only when they got, they were poorly controlled, then we switched to insulin. And that's 10 years, 15 years down the road when other complications start appearing. So it is not, or actually, it's the rule of thumb that a patient will say, "Doc, don't put me on that insulin. My mom, when her doctor put her on insulin, she went blind." And it was the insulin. A month after the doctor prescribed her insulin, she went blind. Well, she had been diabetic for 15 years, poorly controlled, and it was just a matter of time. So most of our patient techs at the clinic were second generation Latino, the children of those immigrant patients. And so they had the trust as they were part of the community. So when they were doing the food exam with the microfilament, and we designed a paragraph spiel about, how complications of diabetes appear. Again, it's the main segment of our population. Diabetes is just prevalent in that clinic. So we saw it as really the most impactful thing, because if we improve adherence of our patients by correcting some misconceptions about insulin, we will prevent complications, improve outcomes. So we enroll and train our patient techs. The physicians in the clinic had a follow-up of reinforcing what the patient's tech had done during their routine food exam. So that's the way we partner, and kind of a nice, simple yet elegant patient education effort that was effective at correcting misconceptions, empowering patients, and understanding the disease process. Okay, the second pillar, patient documentation. Let me start by, this is a real patient. She had applied for Social Security. So 60-year-old patient had a long history with rheumatoid arthritis. She worked as an administrative assistant to an insurance company, by the way. And she had to quit her job because she had to type things, handle phones, and she was unable to do so. Her rheumatoid arthritis had deformed her hands. She had the classic Z swan neck deformities with ankylosed joints. As a matter of fact, her daughter had to help her dress, and the daughter actually got the hanger, from clothing wire, created a contraption with like a loop, and then with duct tape attach it to a spoon, so at least the patient could feed herself, because the joints were so stiff and unable. She was completely loss of the grasping function of the hand. Now, she had come to our clinic, was really frustrated because went through the Social Security application, got denied, got an attorney, and through administrative court, a judge, and got denied. And the reason was basically 4 years of poor physician documentation, because her findings were stable, no signs of inflammation. Of course, there were no longer signs of inflammation because she had literally burned out her entire synovial joints. No pain. Yeah, it was all stiff and with no inflammation. Even there were some early notes that says within normal. Like that was pure, really poor documentation. Responding well to treatment. Yeah, she was finally on some biological medications and disease modifying treatments that had slowed down the process, but it was already too late. So she had to go through an appeal process, and we were finally able to really demonstrate in court that in part that documentation was accurate because there was no acute inflammation, but no one had documented the range of motion. The fact that she was disabled, her hands were completely ankylosed, deformed. She couldn't dress herself. She couldn't feed herself unless she had a contraction. And this is part of that curiosity or interest for the patient. A whole legion of doctors had seen her in clinic, and no one asked her, how are you feeding yourself? How do you dress yourself? Because the deformities on her hands were so obvious, and no one asked that. Even a referral to a physical therapist or an occupational therapist, that was non-existent. So the point is not about note inflation. It's about really reflecting the patient's conditions and needs, and you need to anticipate that. So, sometimes it takes a conversation with the patient. I have had patients who are, have not been completely diagnosed, or you're still collecting all the data because they have moved from another clinic, and they said, oh, I need to do them. And they said, hold your application. Let me compile everything, and we will make a more robust application to help you. So, okay. Now, the third big pillar to be an effective advocate for your patients is to really get to know them, is to know their social history. And let me tell you the story of Miss Jones. She was known to me. I knew her for a couple of years. I knew she was taking care of her adult disabled son, widow. She was a retired teacher. Her son had really severe cerebral palsy, was dependent, really had a wheelchair dependent because of his pronounced kyphosis, required BiPAP at night. So really needed electricity because, had obstructive sleep apnea due to the kyphosis. And she comes to clinic. I noticed her blood pressure. She was really adherent with medications, very compliant with everything. And her blood pressure was really high. I knew she lived in a fixed income. She had a retirement from having been a teacher. And I asked her, are you able to afford your medications? And she said, no, I'm struggling to pay things. And she told me the story. She had a wheelchair accessible van. I'll tell you even the brand, a Caravan, a Dodge Caravan that cost more than a Lamborghini. Um, she owned that van like for 10 years. She was able to get it, make it a wheelchair accessible through some grants and private foundations. But the cost of that car is like $150,000. So it's hard to get. So the transmission broke down. She had to use her savings to pay the $5,000 for the repair. And she struggled on a fixed income. And being, she was very resourceful. She called the City of Austin Public Utilities and said, hey, I need help because I'm running behind. And she got a letter threatening to cut the electricity and the water. And the person who takes the calls goes through an algorithm of questions. And that person was very nice to her. But some of the screening questions to see if she was eligible for any help was, do you own the house? And she's, yeah, I own the house. Do you have, are you unemployed or you don't have a stable source of income? And no, I have my retirement account. Do you have any minor children? And it says, no, I have my adult son. Well, the person said, unfortunately, you don't qualify, for anything. And in that time, it was kind of strict, the process to get into one of those publicly funded programs to defer your payments for. And he said, you can appeal, speak with a supervisor, explain your condition. So I said, let's call. And we make the appointment over the phone. She was there. And, I'm sure she will have been able to do it herself. But it was more effective with me being present there. And again, no lawyering, just saying, hey, she has been my patient for 3 years. I know her son also receives care here at the clinic. He's completely disabled. She's on a fixed income. So it really is impactful for that supervisor. Having the doctor there is like, brings a lot of credibility for that patient. So to the young doctors in this is a little bit of haranguing to you. I think the new generation tends to reduce the social history to just, do you drink? Do you smoke? Do you do alcohol? A few decades ago, when I started medicine, we had the privilege of having initial patient visits last an hour. And my generation didn't justify that to the hospital or clinic administrators who saw that as being inefficient. But that really gave us an opportunity to know our patients really well. And we know that for chronic illnesses, those social factors are essential in adherence to, reducing outcomes, reducing barriers to access care. As a matter of fact, the American Medical Association redesigned the entire history of chronic illnesses. I'm sure many of you know about History 360, where it's about social factors, social wealth, income that are accounted and documented so we can really help patients with chronic illnesses. Okay, this is the curiosity. Is when you don't see something that fits, ask. It's like when you're having that real challenging diagnostic dilemma and you see something that maybe that's the holy grail and you pursue it. So that is like that interest. Let me tell you the story of Miss Garza. So this was a couple of years ago. It was a handoff from the night flow team. So this is more or less, and I'm going to paraphrase, how my upper level resident did the presentation. Dr. Moreno, this is a 70-year-old undocumented Mexican woman with a long-standing history of diabetes and chronic kidney disease, presented yesterday to the emergency room with shortness of breath, secondary to fluid retention. She was found to have profound metabolic acidosis and hyperkalemia and was admitted for compassionate dialysis, which, by the way, compassionate, that's a euphemisms for us to really square down a painful and sad death, but that's for another opportunity. So let me give you some extra context. About a third of our patients here at the hospital do not speak English. Every floor has 3 or 4 iPads for the electronic interpreter, but as a rule of thumb, one is not charged. The other one has the nurses who you cannot find. And then the other one is the physical therapy, the speech therapy, another consultant or another team has it. So then while you set it up, while you wait for the interpreter, waiting for that, it can be 15 minutes and 20 minutes, which, you know, in a busy morning rounds, 15 minutes is precious time. So I always tell the residents, good thing you're attending no Spanish, you know, because it will make the morning goes way smoother. And the resident says, no, Dr. Moreno, the patient is fluent in English. And I said, what? How come did you ask her? You know, most of our patients come from very humble origins. And, you know, yes, we do have some immigrants that are college educated who are speak other languages, but those are really, they're not the norm. And the resident was like, Dr. Moreno, this is just a straightforward compassionate dialysis. Don't complicate the matters. And I said, guys, isn't this strange? We should pursue this a little bit. So I actually didn't even ask her about how long she had been short of breath or how long she had had diabetes. I asked her, how did you learn English? And she starts telling me the story. Well, my parents were in the Bracero program. That used to be a program in the 50s and 60s for migrant workers, agricultural workers. It was a legal program that allows those farmers to come to the United States and pick up cotton, do strawberries and all the vegetables in California, oranges and lemons, all the citrus in Florida, as well in South Texas. And she said, I remember as a child, I have vague memories of attending school. And she said, my parents were illiterate. They actually signed with a cross. They never went to school. Spanish was always the language at home. So that definitely confirmed that she had attended school, some school here in the United States. And she said, my sister, who unfortunately is demented, was born here. She was a U.S. citizen. And I said, her sister was born in Pearsall, Texas, which is a small town south of Austin, about 4-hour drive from here. So her daughter was there. And I said to the daughter, bring me her birth certificate from Mexico. And I forgot if it was later that afternoon or the following day, the patient's daughter brought me. And that birth certificate from Mexico had been issued 12 years after her birth. And I said, this is not contemporary. So I told the patient, I'm going to grab your documentation. She went through their compassionate dialysis. When I come off service, I'll drive down to Pearsall and see what I can find. So the following week, I made the drive down there. In the small counties and in rural Texas, basically the court clerk and the county clerk are the same office, and most of the times the same person. The lady was fascinated to see an attorney from the big city visiting. It was like the first time. She had a heavy Texan accent. She was qualified to have been a character in King of the Hill, the TV show. And she was the sweetest and says, let me help you. We'll see if we can find her birth certificate. And guess what? I found there her birth certificate that had been issued 2 weeks after her birth. It was a midwife, because in those days, for people in the rural communities, poor, it was a midwife, not a doctor. But actually, that birth certificate had been amended in open district court because there was a typographical error. And in Texas, the only way to get an amendment to your birth certificate is in court. If you want to change your name, your gender, whatever is a mistake, you have to go through district court. So there was, the fact that it was proven, because in open court, you have to swear that, yes, that baby it's a U.S. citizen. And so it was really proven that this undocumented Mexican woman was a U.S. citizen by birth. And it all started by, oh, this doesn't fit, So remember that where sometimes the patient care goes beyond the transactional aspect. It isn't just more than, oh, we're providing this patient for compassionate dialysis and just ignore the rest. I think as good internal medicine, where we thrives on those details and that diagnostic challenge, pursue them and ask the question, because it doesn't fit. So, okay. So what are the situations where you can help patients advocate as a physician, where you don't need any legal treatment, any legal training? Denial of insurance and pharmacy benefits, running behind payments or collection notices, missed flight, bus trips, denial of local or state or federal benefits. And how do you do it? So, first of all, is taking a good history of present illness. So grab all the facts, create a timeline. If the patient had already taken steps, what steps, who has he or she talked with, when, what was the result of that conversation, Again, like taking a good admission notes history. Gather the information, the patient's full name, address, social security numbers, account information, household composition, income. It's more effective if you have the patient with you, because you will need a release. So if the person is with you, they can say, yes, I'm allowing my doctor to advocate for me. If not, you will need a HIPAA release. Always, if you can do these things in person, it's harder to say no to someone sitting in front of you or over the phone. If you do this via email or a platform, it's easy to just say no, because you don't have that person in front of you. So it takes longer, but it's also more rewarding and more effective. Contact the right person and official, and often it's go back to the first person who answers the phone or who is there. Treat them with respect, introduce yourself, state your ask, and present the patient's case concisely, highlighting hardships, but don't hide the negative facts, and I'll talk about this. So when you call a consult and say, hey, this is Dr. Moreno, I have a consult. The consult question is, does this patient need a diagnostic angiography? Let me tell you about the story. The same thing. Hey, I'm calling you about this patient. I'm asking if your agency can reconsider the worker comps. Let me tell you the story. It's very similar. Again, you're using skills that you already have as a physician. Be firm, cautious, and very patient. And do not issue any veiled threats. Do not say, we will go to the news, we will put a complaint in the Better Business Bureau, we will get you out of, in the next election cycle. You lost the battle right there. Also, use, I'm going to stereotype, use all your Latino charm. When you're talking with the person and the person is saying, oh, I'm sorry, it's taking too time. Can I put you on hold? Of course. Thank you. Take all the time you need. Thank you for helping my patient. We're really appreciative. So always take that like empathetic, and you can catch more flies with a drop of honey than with 100 swatters. Make sure you document everything and follow up. So one of the things, if they said, okay, we introduce your appeal, or we, there is a committee or someone who's going to look, how long does it take? Can I call you through a direct line? And most of the times people will be willing to give you their number, their extension, rather than going through the regular pathway or, the phone bank, and the menu has changed this time. Okay. So let me give you a couple of examples of how you can be effective. This was a real patient. This was actually like 10 years old. This was 100% service-connected veteran, had a history of diabetes mellitus, peripheral vascular disease with an amputation, had a really severe post-traumatic stress disorder and alcoholism. He was a veteran of the very first war, the Gulf War, back in the 1990s when George Bush dad was the president. And because of his alcoholism, post-traumatic stress, he got into legal troubles, threatening his family separated, had anger management issues. And, with the alcoholism and all those other demons that he was dealing, had really poor diabetic control, ended up amputated. Needed a specialized prosthetic service. The problem is that in Austin at that time, we only had an outpatient clinic for the VA, and the specialized resources that he needed were back up in Temple, which is about an hour and a half drive. But he lost his driver license because of multiple DUIs. He lived with his mother, who was like 80 years old, blind from macular degeneration, so she couldn't drive, and no other family support. And he was actually, despite all his legal things, had done, had kind of got into therapy, was in a music, was a guitar program for veterans with post-traumatic stress disorder, and ran with a music professor and a psychologist in a fascinating form of psychological therapy. Had gone through anger programs, had been sober. So he was doing the right things. The VA was denying again the services because there was nothing. And they said, oh, he's eligible to go to Temple, but no ways to access those services. So we went to Lloyd Doggett, the federal representative for him, and through the community services person, we presented his case. A couple of blocks here is the federal building, and visited Lloyd Doggett's office and presented, and got a letter from the representative to the VA clinic, to the director of the clinic, saying, hey, he really needs help. And how he ended up was that the VA was going to pay for transportation for him to Temple, and managed to get the services that otherwise I think will have derailed him, because he was, saying, I've been doing the right things and now I'm facing, hardships because and by the way, I forgot to mention, he was in a vocational retraining program to get back and regaining employment. So, really success, takes time, but pretty effective. The next one is a sample for a recent patient who was an immigrant from an African country, really advanced prostatic cancer with bony metastasis, really limited mobility because of the pain and pathological fractures. And he says, I know I'm dying. I want to go back to Africa, to my home country, to die there. I want to see my siblings, and had a child there who had not seen in like 5 years. So we got, this is a sample letter, really compelling. The airline didn't gave a special discount because those economy plus seats are close to the bathrooms, and he got it for the regular economy price because we were able to say, hey, he's really limited mobility. Now, this is I mentioned an example about education individual. This is an example of us partnering with the American Heart Association, where we actually got the residents to participate, including some public service announcements. I'll play one, but we did primary cardiovascular prevention. So teaching the community about symptoms of MI and symptoms of a stroke. And it was, visited churches, community centers, supermarkets, like the Latino supermarket on Sundays with a group of residents. The residents loved it. They thought that it was one of their best experiences. I had intentionally selected 4 residents to work with me. And then the major headache that I had afterwards was another 70 residents angry why I had not chosen them to participate in this program. So this is a sample.
Building stronger, healthier hearts in Texas. Cadillac proudly supports the American Heart Association.
750,000 strokes occur in the United States every year. The good news, most of them are preventable. It's all about staying healthy, active, eating well, and not smoking. Learn the signs of a stroke and take fast action. Strokes are treatable.
To learn more about strokes and preventing.
So this was part of the American Heart Association when they coined that term or that acronym FAST to recognize symptoms of a stroke. And, Cadillac, who the dealership here, paid for the public announcement, and the local TV channel also partnered with us. So good ways to empower. We did also the local radio, the Latino channels, the Univision and Telemundo, of course. So these are very short. You need to really memorize the script because it's only 15 to 20 seconds, but really effective. So, okay. I only have 8 more minutes, so I'm going to. Now, many times you have had patients who are facing eviction, criminal charges, immigration, detention, and that goes beyond your training, but you can provide essential testimony or evidence that can really alter. I invite you to, again, sometimes our patients, like the patient that I mentioned, just facing utility, payment of utilities. Sometimes they cannot pay or afford rent and they're being evicted. That is a more complex legal things, but you can find out if in your area there is a medical legal partnership, or reach out to your local bar, and often they have free legal aid services. So it makes an incredible change when you said, hey, I'm Dr. Such and Such, I'm calling on behalf of a patient. He or she is being evicted. Is there an attorney who handles his small claims? And most of the time they say, yeah, we have a program for that. And that really makes a difference. So as a side note, the first medical legal partnership was born in my alma mater. I did my clinical training at Boston Medical Center. Dr. Zimmerman, who was the chair of pediatrics, started. My mentor, David Grodin, who was a pediatrician, even though I'm in internal medicine, that's a long story, but he was my mentor, and we're intrinsic at doing this with George Annas as well, who was a pioneer on patients' rights. So common scenarios, evictions, home ordinance violations, especially in small towns, elder patients who are ill. I have had patients who live here in Kyle, Lockhart, break their hips. They're unable to do physical work. Their yard just grows, weeds, and it looks like like in the human appearance, the front yard is disheveled. And of course, the city, that's an ordinance violation and fines them. And nothing like calling that county or city office and saying, hey, it's my 85-year-old, broke the hip, was in rehab, has not been able, it cannot really bend down or cut, and they will, pardon the fines or reduce them. So very powerful. We already talked about Social Security and worker denial. Criminal cases, those are a little bit more complex. You can testify as to the matter, or in this sentencing to be more lenient. And of course, immigration detention or benefits. So how to work with lawyers. I think traditionally there is a lot of fear about lawyers. Fear nothing, because actually when I'm building a legal case and how I build a clinical reasoning is exactly the same way. You build, you prove things. Where is the evidence, the history, the physical exam, labs is the same thing. Where is the history of the client? You have expert conditions and, or hard evidence documentation, and you make an argument and offer a plan. So there is actually synergy. And actually, remember, before medicine was a science-based profession, it was really close to lawyering and philosophy and art. So you can be a strictly consultant, just advising the attorney or giving context as to the medical problems, or testifying by affidavit or in person at a trial or a hearing. And you can testify as to the substance of the case or during sentencing or benefit determination. So now there is a nuance, because you are the treating physician. There is some bias because you owe that patient a fiduciary duty, but that won't prevent you from actually testifying. It can be very powerful. And I have testified several times on behalf of my patients, is really rewarding, extremely powerful. So, okay. I'm going to give you, because I have 2 minutes, I'm going to give you a few examples of how you can partner with attorneys. During the COVID, some immigration organizations, including a nonprofit organization, I often do legal cases for them, call me, hey, we have a client, she's a middle-aged Mexican immigrant, she was detained, she's in an immigration detention, has really bad respiratory illness. I had not met her. It was just through reading her medical record. I wrote a letter, an affidavit, stating why she should be released. And working with the attorneys, she was not a flight risk because her kids were U.S. citizens by birth. She had never been in trouble with criminal. So she was released. She was released under recognizance. She had to report to an immigration officer every week, but got released from detention when, someone with severe asthma got COVID in a detention center, she probably will have died. This was a patient of mine from Boston, who was a union leader in a country, had escaped because of persecution. And I was seeing him as primary care for hypertension. And I remember he had chronic pain, and he worked in a flower shop, and, long hours in this position. So we always attributed, or I always attributed that pain to position, because of work. Well, one day he comes and says, Dr. Moreno, my attorney needs a letter because I was persecuted and I was shot in the head twice. And I said, really? I had a healthy dose of skepticism. So I did an x-ray, and hold and behold, there were 2 projectiles there, talking about being hard-headed. And we were able to look forensically by the diameter or the measurements of the projectiles, that was a 9mm or a 38 revolver. And I went to testify in his immigration case. And as soon as I put that x-ray and showed the judge, the bullets, the judge stopped the hearing and said, well, I think I had heard enough in this case, and I'm ready to make a determination in the asylum, unless the attorney for the government has an objection. And the attorney for immigration said, I don't object, Your Honor. So really it was the smoking gun or the smoking bullets. And that is a way that you can testify, for instance. So I'll tell you, I'm running out of time. So let me say that advocacy, it's really at the core of the profession. This is not an add-on. I think it's an excellent way to help with burnout, because it makes your work really meaningful. And you feel like, especially when you're fighting those denials of benefit or pharmacy benefits, that you're really impacting your patients. So remember, advocacy is a contact sport. I just highlighted the success stories, but I had countless times where I was not successful. So it can have a very low number needed to treat, talking in statistical terms, but you're not always going to be 100% successful. And it's a multidimensional creature. Again, it's not just visiting Congress and speaking on behalf of patients or the profession. You can do it through education. You can do it by partnering with attorneys. You can do it on your own, just with your patient, making the phone call. So thank you so much.